the Association of American Physicians and Surgeons has a viewpoint on healthcare that we need to hear of more often on Capitol Hill. And I speak to you as somebody who used to sit in the seats and heard what was coming out. And then I got introduced to AAPS, and I was able to see how the practice of medicine should happen and how healthcare could be delivered to patients. And so what we have here today is the executive director of AAPS, Dr. Jane Orient. We have the next president, the president-elect of AAPS, Dr. Ammerling, and a previous president of AAPS, Dr. Alita Eck from New Jersey. They all have their own individual knowledge and understanding, but more importantly, their own experience with dealing with patients day to day. And that's what I really wanted to talk to you about, because when we can deal with the minutiae of the policy, we a lot of times forget the real core of this, which is how the laws affect the way that patients and physicians interact. So when we talk about removing regulations and lowering the burden to reach care or trying to make effective care, we forget that it's really the patient-physician relationship that we're talking about, and that's what I wanted to bring back the conversation today to. So I wanted to start with Dr. Ammerling, let him give a little bit about himself and what he does on a day-to-day practice, but really talk to you about how the laws interact with him and his patients.
Thanks for coming, and thanks, Charlie, for setting this up. ObamaCare is accelerating the demise of the patient-physician relationship, which I will contend is the cornerstone of good quality patient care. This relationship has been under assault for decades, largely from third-party payers who are trying unsuccessfully to control costs. The assault has taken different forms. Price controls on medical services. These have distorted practice patterns, leading to overuse of procedures and prescriptions and underuse of what we call cognitive services. Declining payments for basics such as office visits and consultations drove a large increase in overall costs due to increasing patient volume. And this is accompanied by an inevitable loss of quality. The SGR, which you know there was a fix pushed through the House just a little while ago, is a result of the immediate increase in volume that occurs whenever physician services payments are cut, which leads to overall increases in expenses. Therefore, if SGR were allowed to go through, there would have been a downward spiral of physician payment and rapid exodus of physicians from the Medicare program, which is, of course, why it's never been allowed to go through. There's a huge documentation burden. The effort to quantitate the value of physicians' work, which is truly a Stalinist concept, led to the adoption of the resource-based relative value scale in around 1990. Implementation of this crazy scheme required participation by the AMA and others in creating the ICD and CPT coding system. Doctors then had to learn these and document in the medical record exactly what was done in order to bill at a given level of management. This massive change did absolutely nothing to enhance patient care or control costs. In fact, just the opposite occurred. Incalculable MD time was wasted learning these codes and in trying to add this irrelevant documentation to justify a certain payment. By the way, all the payments were cut around this time after this implementation, which led to increased overall spending in the years following. Health maintenance organizations, HMOs, were touted as the magical formula to lower healthcare costs while improving quality. They accomplished neither. They relied on physician gatekeepers to limit referrals to specialists and expensive procedures, in other words, to ration care. They were extremely unpopular and survived only because of their tax-advantaged status and by limiting exposure to sick patients, so-called cherry picking of the healthy patients. When these were lost, HMOs imploded and were forced to raise premiums and ease some of the restrictions on care. So many, in fact, moved to the preferred provider organizations form, but much of the administrative burden, such as the pre-authorization requirement, stays with us, further deteriorating our relationship with the patient. Payment for performance. This benign-sounding buzzword is in reality a formula for disaster. One major problem is trying to define what constitutes performance or quality medical care. Too often, this comes down to looking retrospectively at patients with good outcomes in an attempt to determine what are called best practices. This is obviously scientifically flawed. Okay? There are many things that enter into a good outcome that are not being looked at. Many pay-for-performance standards are based on clinical practice guidelines developed by so-called expert panels, many of whom have financial and other conflicts of interest. The broad application of these guidelines enforced by payment for performance will cause enormous harm to patients and undermine the patient-physician relationship. And there are many examples of this, which if we have time to discuss, I'll be happy to go into. So Obamacare exacerbates all of these. Since the model for Obamacare is Medicaid, which currently pays doctors $30 for an office visit in New York, I mean, how would you feel about going to a doctor who was accepting $30 to take care of you? I mean, would you accept that kind of a bill for a lawyer? How would you feel about going to a lawyer who was getting paid $30 an hour to take care of you? We expect to see further cuts in physician payment. All other practice expenses are continuing to rise, such as malpractice insurance. So many doctors are going to be unable to provide care for Obamacare patients, or they're going to be forced to give up their private practice and go to work for hospitals or other large organizations where they are going to be forced to do the hospital's bidding. This also doesn't take into account the Independent Payment Advisory Board, which will use price controls to limit access to a variety of procedures it doesn't want to have done. And if you don't believe me on this, Howard Dean said exactly the same thing in an op-ed a few months ago. The documentation burden that we suffer from is not being fixed by the forced adoption of electronic health records. It does allow, however, for the padding of the chart with boilerplate text that can be used to justify higher payments. It directly interferes with the patient-physician relationship by diverting attention from the patient towards the computer, towards data entry, and by requiring input of meaningful use, so-called patient data, which is, of course, meaningless and adds nothing to the patient-physician encounter. In fact, it detracts from it. It's also a major threat to patient confidentiality, which is a big component of the patient-physician relationship. The HMO has now been updated and replaced by the Accountable Care Organization. ACOs agreed to provide all care to a patient for a lump sum of money per patient. To be profitable, then obviously they must spend less than they take in. Physician earnings are also going to depend on this, creating an unhealthy incentive for the physician to skimp on care. This is obviously toxic to the patient-physician relationship. Like HMOs, ACOs will fail. There's no question about it. In fact, 18 of the 32 pilot ACOs failed to control costs, and several bailed out of the program. Payment for performance is being implemented under Obamacare, and it's going to grow by insertion of algorithms into the electronic health record. They will further move doctors away from using their best clinical judgment and treating patients as individuals towards embracing so-called standardized care or one-size-fits-all care with dire consequences for patients. That's all I have.
Dr. Eck, can you come in and talk? You have a charity clinic. Well, you have a private practice as well. So how the government is involved in those in your day-to-day life?
Hi, it's a pleasure to be here. I do have a private practice in internal medicine, and 10 miles away, I've been running a non-government free clinic for the past 10 years. And I've learned a lot. And my topic is how Medicaid affects the physician-patient relationship. Think about it. Before Medicaid began in 1965, we had charity hospitals. They were locally funded, and clinics cared for those who couldn't pay. So students, residents, medical school attendings cared for the people. But then somebody thought that this was somewhat demeaning, and they said, well, in a wealthy country, it was terrible that people should have to rely on uncertain charity. Having to do local fundraising was humiliating, and so why don't we set up a system where everybody gets quality care? Well, but those who enthusiastically support the government systems where everyone pays in, all get the same quality, they find they have to compete with others who want state-subsidized education, preschool, state-subsidized housing, generous state pensions and benefits, and other schemes. There's great emotional and vote-catching appeal. But when the money runs out and the taxpayers are exhausted, cutbacks have to be made, and then there's a lot of resentment. Everyone assumes there's some rich people who are not paying their fair share. I have a primary care practice where patients do pay a fair fee. I don't take any insurance company contracts. But early on, I avoided taking Medicaid as the payments were way too low for us to stay in business. So in 2001, my husband and I started a non-government free clinic. And we've learned very much about caring for those who can't pay. It's on the grounds of our church. Everyone volunteers. We see 300 and 400 people per month, open about 15 hours a week. And we see people who have no money and can't pay. We see people who are on Medicaid. In fact, the Medicaid office often sends us patients because they can't find a doctor. Well, we hear stories, and I'm going to tell you 3 real quickly. If a Medicaid patient comes to an emergency room, they're stabilized. One woman came in with abdominal pain. She was on Medicaid. They found she had gallstones, but because she didn't have a fever and her liver enzymes weren't elevated, they sent her home. They said, go find a surgeon. Well, she couldn't find a surgeon. She would call all the surgeons' offices, and she never made it past the front desk. Well, she had more abdominal pain. She came to our clinic. I knew she had gallstones. She had to have her gallbladder out. So I just gave a surgeon a call and said, look, we'll pay you. Could you take out her gallbladder? We came up with a fair fee. Our clinic paid him. And here it was, local people, doctors contracting with other local doctors, and it was a local clinic funded by local donors, and we got the job done. We didn't have to ask Washington, D.C. for permission or accept the payment that they would give. Another man came to our clinic. He wanted to get on disability because he was so exhausted. He had huge nasal polyps that needed to come out. Well, he was on Medicaid, and surgery was approved by the hospital, but there was no doctor who would do it. And it turns out that I said, well, what would that cost? I'm thinking, now here's a man who wants to go on disability, which would cost the taxpayers a fortune because they have to pay for the rest of his life every month, a disability payment. I said, well, what would it cost? He says, well, one doctor was going to charge $1,600 to take him out, and I had no money. I couldn't do that. So I said, $1,600? Well, what a bargain. Why don't I just call an ENT? Our clinic could pay, and we did. So we got the job done. Well, this man just thinks we walk on water, and he was so grateful for what we did. We used common sense. We had no government red tape to deal with, and we solved the problem. The third case I'm going to tell you about, the most egregious case, was a 48-year-old woman who broke her femur. That's the big bone in the top of the leg. She broke her femur 3 years ago. It was never fixed. She was on Medicaid. She was in a wheelchair. She couldn't stand on her leg, obviously, and she was in great pain all the time. I met her about 1.5 years into this, and I found out now the case was very complicated. The surgeon, if he took Medicaid, would get about $800 for a 4-hour case and full liability. So every surgeon looked at her and just said, well, I think that maybe you just ought to go find some other doctor or go to some tertiary care center or somebody will do it. Well, nobody would. She couldn't find anybody to take care of her. And the interesting thing was this woman was she came into the emergency room probably 10 times during this 3-year period. Was always in pain. She'd have this spasm, and they would say, yeah, leg's still broken. Oops, sorry. Here's some pain medicine, go home. And it was almost like, what is with these residents? They don't quite understand. This woman, why don't you have this can-do attitude? Why don't we fix it? And one said, oh, maybe you're going to have your leg amputated. Another one said, maybe a little minimal operation could be done, but you'll never stand on your leg. So I talked to a radiologist, and I said, just take a look at this. He says, could this leg be fixed? What could they do? And he says, well, yeah, they could just do a hip replacement, and she would be fine. So I took that, and I said, all right. I called an orthopedic surgeon, and he looked at the x-rays, and now I said, we're going to pay you to fix her leg. And we did. It was about on February 18th. He put in a new hip, and in another couple of days, it'll be 6 weeks, she will be able to fully weight bear. She'll be able to stand for the first time in 3 years. She'll be fine. And we paid him. Again, It was local doctors working with a local hospital, took care of a local patient locally with donated funds, and that's the way charity should work. Everybody is ennobled by that. When you have to ask Washington, D.C. for permission, and when they're running out of funds and it's way too expensive a program, that's what happens. People just don't get the care, and it affects what you can do for people. Take the federally qualified health centers. Now, those are the centers that are supposed to increase access to care for Medicaid patients for all these reasons. It costs 10 times more for them to care for somebody, almost twice as much as what we would charge in our private office for patient care in these federally qualified health centers. And sure enough, doctors are paid really well, everybody's getting lots of money, but the taxpayers are taking it on the chin. And they want me to enroll as a non-billing Medicaid provider, and something which I refuse to do, a non-billing Medicaid provider. Think about that. They want me to enroll in a program I'm not going to bill for. I think, is this a trap? What is this? And it turns out what it is if I would see a Medicaid patient in my private office and he didn't tell me he was on Medicaid and was just willing to pay, he just had some money, and I did, and then they found out that I charged, I could be guilty of fraud. So I would never sign that contract. And it just seems, what is the government doing? Why is it getting in between my patient and myself? Accountable care organizations, as Dr. Ammerling said, the organization is given a large amount of federal funds. And they're expecting to be accountable for the outcomes and how they spend the money. And if there's money left over, there's gain sharing where the doctors all get paid a little extra because they save so much money. Well, think about it. You're a patient in an accountable care organization. Your doctor is going to get paid more if he does less for you. Doesn't that sound like a perverse incentive? It sounds like a little bit dangerous to be that patient. And sure enough, Ezekiel Emanuel, the physician who helped to come up with the Affordable Care Act, he thinks that doctors are greedy, they can't be trusted to make good decisions, so he thinks that the government should decide. And he goes, patients should never be paid, doctors should never be paid directly by the patients because that's going to be corrupting. Well, what other industry or what other profession is that considered corrupting? No. The bottom line is Medicaid costs the states a third of their budgets, and it does a very poor job of increasing access to care. Taxpayers can't afford to pay the physicians more. The Affordable Care Act is going to double the Medicaid rolls in our state and a lot of states, which is not the way to increase access to care. Unsustainable in a faltering economy with a debt that's growing by trillions every year. We need to get back to real charity, where the physician sees the patient for no pay in a non-government free clinic, and the taxpayers are excused from the transaction completely. And a reasonable trade-off would be for the state to protect those doctors who donate a significant amount of time, say 4 hours a week. This is the model we're coming up with. And let the state simply protect them in their private practices. Doctors donate 4 hours a week. They get protection in their private practices. New Jersey has a Senate bill, number 94, that's been drafted. The legislators in a Democratic controlled Assembly and Senate are dragging their feet on it. But it's been introduced also in Virginia by Delegate Bob Marshall. It's waiting to be passed. And this is saying that doctors would donate the 4 hours a week and would get the protection in their private practices. Eventually, the legislators are going to have to wake up because we have to stop wasting money on programs that fail in so many ways. Well, we have very loyal patients, and here's what happens. Many start out in the free clinic, but as they get out on their feet, they come over and they get jobs. They're so grateful to us, they pay us in our private practice. And many come back to volunteer because they felt so ennobled and grateful for what we did. The community is enhanced. The friendships are real. The private patient-physician relationship is intact. And it's a far more rewarding way to practice medicine. Thank you.
Our last speaker today is Dr. Jane Orient. She's the executive director of AAPS, and in her day-to-day practice, the government is not involved, and so we want her to tell her story. Dr. Orient.
Well, thank you all for listening. I was a VA doctor and university doctor for about 5 years, and around 1981 I made my escape into solo private practice of adult medicine. I never took a dollar from Medicare. I never signed contract number 1 with managed care organizations. And the purpose of the Affordable Care Act is to get rid of people like me. It's to destroy private medicine, to destroy fee-for-service practice, which means paying people for the work that they do. This is the stated intention of the architects of the Affordable Care Act. So I would say Obamacare needs to be repealed. That is necessary if medicine is to survive. It is not sufficient. I've been with AAPS for about 1983, and I'll tell you a little bit about my reflections on that basis. In the 2nd century BC, Cato the Elder, in every speech that he gave to the Roman Senate, said at the end of the speech, "Furthermore, I say that Carthage must be destroyed." And people kind of repeated that as a ritual. And of course, you know, Carthage was destroyed. The Romans tore it down. There was not one stone standing on another, and they salted the earth. As you also know, Rome, several centuries later, was also destroyed. There were many reasons for that, but perhaps the most important one was that Rome debased the denarius. They destroyed their currency, which no longer stood for anything valuable. Well, coming up to our own time, there was a man that I learned about recently, Representative Robert Fleming Rich from Pennsylvania. During the New Deal, whenever they introduced another big spending bill, asked for recognition and said, "Mr. Speaker, where is the money going to come from?" And people started, I guess, sort of mocking him. They started repeating this. But you know, I don't know of anybody in our Congress today who's asking that question anymore. They just assume that the government's going to print it, that it's just going to magically appear. And the Republican House of Representatives gave Obama a blank check on this. So we think that Obamacare is a problem, but you know, the problem came long before then. Ovik Roy recently did a paper in which he showed the huge financial burden that Obamacare is going to place on America. $1 trillion, $2 trillion, $3 trillion, who knows how much it's going to be eventually. But he draws a little graph and shows that this is really only a small fraction of what Medicare and Medicaid are already doing. Back in 1965 or before that, the chief obstacle to passing Medicare, which we would call socialized medicine for the elderly, was not the AMA. It was one Wilbur Mills, Democrat from Arkansas, chairman of the House Ways and Means Committee for decades. And he said, "I'm never going to let Medicare come to the floor because it's going to bankrupt the country." Well, when LBJ had his landslide victory, Mills said, "Well, I can count." And after that, he told LBJ, "Well, we've got a good thing now after he shepherded Medicare through the Congress. We can run on this forever." And that's what the politicians do. As soon as medicine is politicized, they always need to be expanded. There are always more needs. You can always go back and run on it over and over again. There are a lot of similarities between Obamacare and Medicare. Talk about lies. Of course, we know how many lies Obama told, like if you like your doctor, you can keep your doctor, et cetera, et cetera. Well, what about this lie? Section 1801 of Title 18 of the Social Security Act, signed into law by LBJ in 1965, which says, to shorten it a little bit, nothing in this title shall be construed to allow any federal officer or employee to interfere in any way in the practice of medicine, including the compensation for Medicare services. And you know what happened today? Well, we just had this SGR coming up for discussion. Another similarity between the two is that it puts people at odds with each other. It causes enemies. It causes a war of all against all. The workers are placed against their employers, the rich against the poor, the young against the old, and worst of all, the doctor against the patient, and the healthy people against the sick people. Please understand, Medicare is not insurance, neither is Obamacare, neither is managed care. Insurance is a voluntary contract to share risk. And premiums are based on risk. Otherwise, who would sign up if he knew it was going to be overcharged? Medicare is allegedly voluntary, and so is ObamaCare, but you know that that is a travesty. But what we have had since medical prices doubled or tripled since 1965, we've had all types of government efforts to keep down this cost, having disconnected the normal regulatory mechanism of the free market, which is people spending their own money for what they value. Now, something like 85% of medical services in the U.S. are third-party paid. That means somebody besides the person who received the services pays the bill. And so we have price controls in Medicare and other means to try to put the lid on this. Well, what happens when the doctor is working for somebody else? This is an old German proverb. We've distributed this pamphlet since about 1953. Whose bread I eat, his song I must sing. If you're on Medicare, or if you have a managed care contract, or the insurance company is paying your bill, your doctor is not working for you. He gets paid on the basis of some numbers that he writes on a claim form that goes to the insurance company. One way of putting this is that your doctor is a double agent. To show you something about what this means, I just got in the mail this week. This is from the Maricopa County Medical Society journal. It's the Medical Society in Phoenix, Arizona. And this is a handout for patients. A little tear-out the doctor gives to the patient, and it's like this. Patients used to be denied health insurance due to the higher cost of pre-existing medical conditions, but this is no longer legal. Will the tide turn to discriminate against patients who are non-compliant? Time will tell, but your best defense is to follow medical advice. You do not want to have something a problem on your problem list, non-compliant patient. And it may be that being non-compliant is not all. If you're just sick and you're not getting well, you are a liability to your doctor. That his mortgage, his ability to send his kids to college may be at stake if he's in one of these accountable care organizations and he gets paid basically for denying care instead of giving care. There are no death panels, they say, but what has happened is much worse. The rationing agent is not going to be a panel that you could appeal to. It's going to be your doctor. Your doctor. He's probably signed a hold harmless clause with his managed care contract that says that if they decide not to pay for something that's a covered service, he may not bill the patient. He may have no way of getting paid for the services that it costs him plenty to provide. So this is kind of a covert form of rationing that totally destroys the patient-physician relationship. Doctors can't trust their patients either because Medicare recruits these senior fraud squads to go around and try to find something to rat their doctor out about, or the patient might actually be a federal law enforcement cop who's wired to try to entrap the doctor into doing something like prescribing a pain medicine. So doctors cannot trust their patients these days. Now, it used to be that you as a patient were protected by the culture. Doctors loved their work. They got to know the patient and his family over a period of many years and really deeply cared about the patient and about doing a good job. And there was the oath of Hippocrates. Well, do you know what? We don't have the oath of Hippocrates anymore. We have something that may be called a Hippocratic oath, but it's been altered beyond recognition. And instead of being responsible to the patient or to some higher authority or universal law, the physician is primarily responsible to the state, to society, to the population. It's this charter of professionalism that doctors have now. Medical students are being taught that their job is to serve optimum population health. And some of them tell me that they're told by their professors, you better get with the program. If you're not willing to restrict medical care to these patients who are too old or too frail or too disabled or whatever, you're not going to be able to make a living. And doctors, in fact, could actually be booted out of the profession for not doing this, or certainly booted off their managed care plan. And in Obamacare, there are certain provisions in the regulations that say, if you're not following the best practices, we won't allow you to contract with any of our health plans. So population health, it's all the rage, and all the medical journals that you read. Just as an example, one that came a few weeks ago, Harold Sachs, who's a big deal at Dartmouth Medical School, he was saying, well, what we're going to do is we're going to have the electronic health record, and we're going to keep track of all these things, all these 5 things. They're really sophisticated and advanced, just dumbed down as you can be. Your smoking history, your blood pressure, your cholesterol, and all of that. We're going to keep records on this, and we're going to make sure that you all are on enough drugs to keep these under a certain level. He didn't really say it that way. But in several generations, we will see the benefit to this. Everyone will be healthy, and we won't have to spend all this money. Of course, this is the age-old promise of socialism. We'll sacrifice the current generation, but in the future, 2 generations from now, everything will be just fine. So I would say that your protection as a patient is to have an independent doctor who is working for you, who believes in old-fashioned traditional medical ethics, who wants you to get better, and who is not beholden to all of these third parties, including the government. Well, there's a war against us. Out-of-network doctors, there's big penalties. The patients may have to pay another separate deductible if they see an out-of-network doctor. The reimbursement for the services may be much less than if they see the in-network doctor who's under the thumb of the managers. There's this PICO system in Medicare that is making it very, very difficult for doctors who were opted out of Medicare to write prescriptions, to order referrals, to order laboratory. Dr. Eck told you about one. They're trying to stop the pharmacies from filling prescriptions for Medicaid patients if she writes them a prescription. It's like telling an auto mechanic, sure, you're allowed to fix cars, but you're not allowed to use any tools. Independent doctors could do a lot to solve the problem and to bring medical costs down. People have calculated that if you look at all the huge amount of money, something like $2.7 trillion that goes into the medical sector of the economy, about 40% of it is sucked into something other than medical care. It doesn't pay doctor bill, it doesn't pay hospital bill, it doesn't buy wheelchairs or oxygen tanks or drugs or x-rays. It's just gone. It's gone into all this infrastructure, these paper shufflers, these quality assurers, et cetera, et cetera. That we could save 40% off the top by getting rid of all of these intermediaries and have a much better product as a result. But instead, what are we doing? We're having like the ICD-10 codes, which are just an exercise in pure absurdity. I guess the House just passed a bill to delay it for a year. Well, why don't they get rid of it to begin with? It's just a total waste of time and another barrier between the physician and his patients. Well, I think ultimately to get back to medicine between the physician and the patient is the solution to our problem. But I think the people who are sitting in the realms of power now are saying, furthermore, I say that private medicine must be destroyed. I think our reply to that maybe should be, and I'm not hearing anybody say this, but somebody should, so I will. Furthermore, I say that socialism has to be destroyed because it is evil, it is lying, it's based on theft, it's based on setting people against one another. We have to get back to freedom, to constitutionally limited government, and to restore the patient-physician relationship.
All right, let's see if we can move. We're going to move to questions here in just a couple of minutes, but let's see if we can move a patient through coming to see each of you and see how the government's involved. Maybe we can end up with a recent case in AAPS where a physician actually had to spend time in jail for making an error for doing some notes later. But Dr. Amerling,
Well, what I would consider a good encounter with me or any physician would be a relaxed environment, no pressure. I would sit down with the patient, offer them a glass of water if they're thirsty, and try to figure out, ask them what's wrong with them, and try to delve into the problem and get historical information that's going to lead me to some differential diagnosis, and I'm going to ask a few more questions to sort of refine it, and then do a careful exam focused by the chief complaint, and then have a discussion with the patient. Now, a really good job for a moderately complicated patient, and since I'm a kidney specialist, virtually everybody I see is complicated, would take half an hour to an hour, depending on the extent of the comorbidity, shall we say. Well, in my practice, I've got maybe 15 to 20 minutes, or the pileup starts to occur out in the waiting room. So that's pressure number one that is very unpleasant, and it forces me to go quickly. Then the next problem is that I now have to enter this encounter into a very cumbersome electronic health record in a computer that's off to the side. So I'm sitting there typing away, trying to listen to the patient, trying to focus on what they're telling me, not just with the words, with the body language. I'm looking at the computer entering data, and I'm clicking with the mouse instead of looking at the patient's eyes and seeing what I can pick up from them. And it's a glaring, major intrusion into this relationship. It provides absolutely no value to me or to the patient. In fact, it detracts. Then I'm bothered constantly by requests for prior authorization for this, prior authorization for that. So after 20 plus years, 30 years now of training, I'm not able to figure out that somebody needs a CT scan. I have to get permission from a person that might have a high school education who's going through a list of protocols and questions, and they're going to second guess my decision-making on this particular case. Well, the truth is, they almost never turn me down. They almost always approve whatever I want to do, but it has taken 20 minutes. I'm not getting paid for that time. So that is just an example. We're being asked to indicate that patients' blood pressure is checked, as though I'm going to ever see a patient without checking their blood pressure. There are definitely going to be pressures to control blood pressure that are coming down the line, pressures to control the hemoglobin A1C, which is an indicator of diabetic control. If you do this in a way with medication, you're very often going to be forcing these patients to get heavier, which is really their underlying problem. So this treatment by number, treatment by a target number, is a very bad way to practice medicine, and that is increasingly what we're being forced to do.
I don't take Medicaid, so for me to tell how Medicaid affects the private patient-physician relationship is a little bit difficult. But I can tell you what I do in our clinic, which is the opposite. Instead of having to sit by the computer, do all this documentation, instead of having to fill in these forms and the codes and come up with something to justify getting paid what Medicaid would pay me, I don't have to do all of that. In our clinic, we just have a regular chart. We look at the patient, we hear their story, we find out everything else that's going on in their life, because that's why they're coming to a free clinic. Usually their lives are in chaos. And we can empathize with them, sit with them, and then we've got food and clothing across the way that they can get help, and really show that we care and pull them out of the problems that they're in. On the contrary, when they go to a Medicaid office, which is usually full of people who are waiting, and they say it's very impersonal. They might get a prescription that Medicaid doesn't fill. They wind up coming to our clinic, and we can help them with the medicines that are donated to us. We can be very flexible in how we take care of people instead of having to follow some algorithm that the government approves of. Much better way. And in fact, the medical students who come to our clinic love to come there. They get to see a lot of different things. It's relatively fast-paced because we're not wasting a lot of time, and we can really teach them how to find out more about the patient, because often the things going on in their lives are what are causing their symptoms. It's a much more satisfying way of practicing medicine, and the patients are really grateful and happy that we're there to do that. So that's the kind of thing we need to promote. I would say that the government getting into medicine is just counterproductive. It's not the least bit helpful in making us better physicians and making the outcomes of the patients overall better. And they're not necessarily healthier. I mean, what is the purpose of helping a patient? You want to make them pain-free. You want to treat what's wrong with them and get them on their way so they can be productive and work and all of that. It's not a matter of keeping numbers in order and and all of that. And so that's our approach that I think is much healthier. And I think leaving the government out is the way that we would see much better patient outcomes.
And Dr. Ammerling talked about how he has to kind of sit to the side of his patient and enter in the information in the electronic medical health record. There's somebody like me who could say, hey, why doesn't he just not do that and then all of a sudden turn around and just hit yes, 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 or CCC down the road. I do know that he can't do that for several reasons. A, he wants good information afterwards, but there's other reasons too. Can you talk a little bit about that?
Well, when I was at the VA, we got these new forms in that were just awful. They were checklists and so on, and I never believed anything that was written on them. I do believe if somebody scribbles something down in the chart, because like a heart murmur or something, or no heart murmur, because I think the person actually did listen and took the trouble to write it down. We did a little study at the VA where we had research assistants following doctors along with a stopwatch. So I know for certain that the nurse practitioners who were in the study wrote down things that they did not do because the research assistant did not observe it. So I don't think you can rely on that information that's in the chart when there's just huge volumes of it. You don't know who put it in. It was probably not of any importance to the person who did it. I guess Dr. Ammerling works for a university and he's constrained. I work for myself and I keep my notes in code, that is to say in handwriting, and I've never really had any problem with that. One patient I took care of who moved to a different location was an elderly gentleman, a retired pilot, a first-rate individual, but he did take some time and he was complicated. I could not find him a primary care doctor within a 150-mile radius of his new home. Finally, I found him an opted-out physician who would see him for Medicare and to pay privately as an opted-out doctor. It was a reasonable charge. The patient was delighted to pay it. In the meantime, he needed a CT scan of his abdomen because he'd lost a lot of weight, symptoms suspicious of cancer. I ordered the CT scan. The scanner was available. Nobody, I don't think, would have argued about the indication, but the facility refused to do it because I'm not enrolled in Medicare and I don't have an NPI. Fortunately, he did have a specialist who was willing and able to order the test for him. But this could be a real problem for patients of doctors who are not enrolled in the system because the government is actively blocking their access to care.
Yeah, the medical health record, the electronic health record is full of a lot of garbage. I mean, when you have something entered by one practitioner into the electronic health record, what often happens is that others will simply merge his note into their current note. So I've done many medical liability malpractice case reviews, and I get sent charts from hospitals and doctors' offices that are literally a foot thick. But when you go through it, almost all of the material in there is complete nonsense, utter rubbish, of no real value. In the hospital, it's all these notes that are just duplicates of the previous note that everybody's copying and cutting and pasting. And also all these checklists that the nurses check off that no one ever looks at. And it doesn't do anything for patient care. It's just pure time-wasting, unnecessary paperwork documentation. When we installed the electronic health record at our hospital in New York, our patient satisfaction surveys took a nosedive. And it was easy to see why, because the nurses and the doctors were spending their time entering data into the computer system instead of spending time interacting with the patients. And the most important thing when you're a patient in a hospital is that your nurse is taking care of you and seeing you, and that your doctor comes by and spends time with you. If you've ever been a patient, you'll know that that's true. Now, you're all young and healthy and probably have never been inside the hospital as a patient, but that is clearly what makes the difference in a good versus a bad hospital stay. So it was not a coincidence that our patient satisfaction numbers plummeted with the introduction of the health record.
Yeah, can I ask one more question before I sit down? And that's, Dr. Orient, you said that this current law puts the doctor against the patient, and a lot of times the doctor and the patient are at odds. Can you explain just a little bit further about what you mean?
Well, the doctor can be actually sent to prison or prosecuted because of what he writes in the chart or what he doesn't write in the chart. And this is going to be worse with Obamacare because the doctor's going to be required to follow best practices. One of our members recently got out of serving a 10-month sentence in a federal prison because he made some mistakes in his operative reports. He was acquitted of fraud. He saved the lives of elderly, extremely sick patients who were bleeding to death, but that didn't count. He made a mistake in dictating his operative report. And government, well, obviously, you must have had a motive for doing that, and you must have been trying to defraud us, even though it didn't make any difference. But, you know, with all this emphasis on quality, and all this is supposed to increase quality, I see some things that are just really blood-curdling, like a man who goes to my church, went in for knee surgery, didn't come back for several weeks, so I finally called him up, and his wife was trying to put it two together from what she overheard in the cafeteria or people talking in the hall, because nobody ever bothered to tell her what was going on. But apparently, they dumped about 1.5 gallons of saline into this man without noticing that his catheter was plugged up. So he got obstructive uropathy, nearly shut down his kidneys, had heart failure, and all of this, perfectly healthy guy, went in for knee surgery. But because of the simplest kind of thing, watching the eye and the input and output, they nearly killed him. Why should this be happening? This is supposed to be one of the best hospitals that there are. But surgeons have told me, if you've got to go in for surgery, take your own nurse. It's really frightening.
I got a call from an insurance company to ask why a patient was taking a certain medicine. And it turns out that the electronic medical record, the doctor had clicked one, it was an alphabetical order for the medicines, and had clicked something right above what the actual medicine was, and one was for an HIV medicine versus an antibiotic. And so here this person was on HIV medicine. I said, well, why? I didn't realize that they were. If this had gone online, that person would have been scarred for life, and everybody would assume that she's HIV positive, which then affects everything. It affects life insurance, it affects everything as to their future care. But it was a mistake. And once something is out there in cyberspace, to pull it back and to change it is extraordinarily difficult, which is why we've got an electronic medical record in our office, but I'm able to just fix it, and I'm never going to put it online, even though Medicare is going to now dock me 2% per year or for every thing I do, because I'm not sending them the medical records. I don't think that's the right thing to do, sending them the medical records wholesale. And it affects the privacy of that patient, which I think is extraordinarily important. And unfortunately, I was able to catch that error and explain it to the insurance company, but that's the kind of thing that happens when everything's electronic and goes out there into cyberspace.
Well, just because you're a young and healthy group, I'm going to recommend that you stay that way. You can't completely delay the aging process, but eat well, get a lot of sleep, avoid drugs and liquor, and take care of yourselves. Find a private physician who will take care of you. As the current generation of doctors that are practicing who are my age start to retire, start to hang up their stethoscope, there are going to be fewer and fewer physicians around who have the level of experience or the wisdom, shall we say, gained over years. You're going to be treated by a younger cohort of doctors who are bright. There's no question about it. They're very smart people. I work with them. But they don't have the same commitment that we had in the old days, and they also have been trained differently. They've been trained to think in terms of algorithms and protocols as opposed to individual signs, symptoms, and prescribing individually. It's public health. It's not individualized health.
Well, thank you all for coming. If you have any questions, we'll stay around afterwards. I know that this has affected me when I was sitting in your seats. I went to an office down the street, and I was told on my way in that I could ask the doctor one question, and only one question. He was going to have to move on. And when the doctor came in, I said, really, I can only ask you one question? And he looked down at his chart and said, oh no, you have good insurance. You can, I can stay in here for a little while. And so, I mean, this is real, and this is something that we need to work on right now. So thank you again for your time, and I'm sure I'll see you around Capitol Hill.